Good evening, everyone. Welcome to another town hall. I'm Sam Lim. It's good to be with you all again. And this is Lupus and COVID-19 in our community, the second Sunday monthly town hall. Proud to be here in front of you. Can't have had this done without support from Terry and the staff at the Lupus Foundation of America Georgia chapter, as well as Emory and the GOAL Project and the Georgia Council for Lupus Education and Awareness. Okay, so this is the heat map from last month, and you can see this is how it is now. Last month, and now. Some areas, thankfully, have relatively cooled off, but as we all know, we continue to have a lot of cases in the US, but you can kind of see a lot of the other areas, especially in Eastern Europe, parts of Europe, including Britain, continue to have a lot of cases as well. This chart shows how cases per capita have changed in different parts of the world, and over the last 90 days, the US and Canada, and it's mostly driven by Canada, but it's in this red line here, and you can see how we have completely overtaken the rest of the world in terms of the number of cases per 100,000. Europe is in this light blue here, and it was much higher than the US for a bit, and then it kind of plateaued, and it's been relatively steady, but it hasn't reached as high as we have. The Middle East, as you saw in the previous map, has had a lot of cases too, overtaking Europe, but it's kind of plateaued as well. In Latin America, which was really high because they didn't have the amount of vaccine penetration that we had throughout the summer, which wasn't ideal even back then, but we had a lot more relative to them, and they went from a relatively high level to coming down, actually, relative to the other countries and areas. So this is the US in terms of hotspots last month. And you can see the areas involved are predominantly Florida, Louisiana, Arkansas up into Missouri, and you have a little smattering up in the Northwest. This is this month. Nebraska is refusing to play ball. For some reason, they didn't report numbers recently. But just looking from last month to this month, the overall hotspots have spread throughout the country. But by and large, the South and the Southeast is the most thoroughly penetrated in terms of COVID cases. And really the center of COVID now is in Tennessee, which has really high numbers. And, West Virginia is high, but also Alabama and South Carolina really have very high rates in the Southeast. So we're kind of bordered along all three sides, and Florida is still very high. And Georgia remains high too. So this is the flow of cases over the past several months in the US. You saw the last peak, and then we went down in the spring. And then with the rise of the Delta variant, you see that it's gone very high. And there's kind of a hint that it may be leveling out and starting to come down, which would be great, but still it's very high in terms of where we used to be, especially in the spring and early summer. The testing rates have gone up as a result, and the hospitalizations have gone up as well, although they've started to plateau, which is good. And the number of deaths have gone up, which really sort of always lagged behind the hospitalizations. And so it's expected that that will probably continue to go up, even as the hospitalizations flatten out and hopefully come down in the near future. These are hotspots in Georgia last month, mostly towards the south, bordering on Florida, which at that time was the highest in the country. And this is what it is now, pretty much throughout the state. Certainly a lot more in the middle and the northwest portions of the state as well. Kind of speaking to kind of the cases all around us, really. You have Tennessee up here that's really leaking a lot of cases up here, and then South Carolina, and still the effects of Florida. So we have it from all sides and from within as well. So Georgia, mirroring kind of what's going on in the US, we have very high rates, similar to what happened last winter. And we have to remember this. I mean, it was extremely high back here without the vaccine so much. Yet here we are again with high rates of Delta, especially in the unvaccinated, which is really driving the high rates now, even though we have the vaccines that brought us down so nicely. But it's that emergence of the highly contagious variant of Delta that is spreading like wildfire, especially in the unvaccinated group. And that's what's really driving, both in the US and Georgia, this rate up here. And in Georgia, it seems to be somewhat coming down in terms of the cases, and we hope that we've hit our peak, but we'll have to see, and there's still a lot to come. So we can't rest on our laurels. Testing similarly has gone up. As a result of people getting more symptoms and being more attuned and having more cases go around. Hospitalizations in Georgia still continue to go up. It hasn't flattened out yet, and deaths continue to rise. So news since last town hall last month, the ICUs have been near full capacity in the southern states all around us and in Georgia, despite the fact that on the surface, it looks like these numbers are good. The US passed 74% of adults with at least the first dose of the vaccine. But again, this is truly a pandemic of the unvaccinated. And the rates of vaccination of even the first dose of the vaccine in the South, in the Southeast, is not near 74%. The Atlanta Falcons are leading the way, maybe not today in terms of the score, but we're very proud of them in terms of being 100% vaccinated, the first team in the NFL to do so. The Pfizer vaccine got full FDA approval, and we're fully expecting Moderna to follow shortly thereafter, and eventually J&J. It's just a matter of timing. Pfizer was the first one to come out, get emergency use authorization, and so they're just a little bit ahead of the game. More corporations are mandating vaccinations or using incentives to encourage vaccination. And really what's taken over the headline continues to be the Delta variant, which is now nearly 99% of the strain that is circulating in the US is of the Delta variety. So it is by far the dominant strain in the US as well as most of the world. Just want to take this question on right away. Should someone who has lupus take the COVID vaccine? Should they take any vaccine? And because lupus is a condition where the immune system isn't, it leads to an overactive state, and therefore it's treated with medications that lower the immune system and sets you up for a higher risk of infection. Any use of an approach to help protect you from infections by strengthening your immune system, helping your immune system direct its weapons more effectively against viruses and bacteria is helpful. So all vaccines, as long as they don't contain any live virus, which everything listed here does not. There used to be an old shingles vaccine that had a component of that, but the new shingles vaccine does not. And the FluMist, the type of flu vaccine that you could get through the nose, which I don't think is available anymore, had a little bit of live virus. So, getting a flu shot shouldn't be an issue. And every other vaccine, really, there's no reason to stay away from it necessarily, just because you have lupus. You always have to talk to your doctor specifically about the issues that you've had with previous vaccines and what type of lupus. But in general, there is no blanket warning against vaccines in general. In fact, there's a blanket encouragement to get vaccines in general for a lot of other things besides COVID, but also COVID itself. The American College of Rheumatology came out with a general recommendation and continues to hold by that people with lupus and other rheumatologic conditions, especially those that are on medications to suppress their immune system, should get vaccinated against COVID. Again, a lot of caveats there, especially in terms of some other medications that you may have been on, previous reactions to vaccines. But short of that, you should have that discussion with your doctor and really consider it strongly. This is a publication that came out earlier this month in the CDC publication, the MMWR. It just tells you really how infectious Delta is. I mean, COVID is in general, which is why it spread so quickly, a little bit more quickly than you would expect for the common cold. It's more infectious that way. But this new Delta variant is even more infectious than the original version that came out that we were dealing with. And this just sort of illustrates that. It highlights an outbreak in an elementary school where a teacher that was unmasked and unvaccinated was reading to children. And there were 26 confirmed cases of COVID that came through the contacts and the students of the students, as well as the contacts of those students that came from that one teacher. And just related to how the virus gets transmitted through respiratory droplets. The closer you are to somebody, the higher the volume of that those droplets are, and the fact that you don't have barriers between you and that other person for those droplets to get stuck on. It really speaks to the fact of how COVID moves. And this teacher was standing right here, and 80% of the kids in the first and second rows got COVID because there was no masking to prevent the droplets going back and forth. The teacher was unvaccinated, so therefore would have a higher viral load, more viruses in their lungs and their nose to cough out or spit out when they were talking as a result. And you can see it sort of flew back into other students as well. And these students may have interacted with some of these students in the front too. So many of you probably heard that the administration now is really starting to ramp up incentives, if you will, and pressure otherwise to try to facilitate vaccination throughout the country. The president unveiled a six-pronged strategy, as he sort of outlined, relying on regulatory powers and other steps to try to boost vaccination. He said the Department of Labor was developing an emergency temporary standard that will require all employers with more than 100 employees to ensure that the workers are vaccinated or tested weekly. The administration will also require workers in healthcare settings that receive Medicaid or Medicare reimbursement to be vaccinated, a move that applies to nearly 50,000 providers and covers more than 17 million healthcare workers. And Biden has signed executive orders requiring vaccination for all federal government workers, as well as employees of contractors that do business with the federal government. And this, as you can expect, is getting a lot of pushback, especially from the other side of the aisle and from states with governors, with Republican governors specifically, like Georgia. They're threatening legal pushback in terms of fighting these mandates. And the companies themselves are trying to figure out how to institute a lot of these regulations too. So it's going to be interesting to see how all this plays out. Um, I wanted to just segue into this concept of waning immunity as we talk about this in the context of the COVID vaccine and our response to it. But I think this is a good time to remind you that the concept of waning immunity is normal and expected. First of all, we get immunized to things naturally all the time from birth till this very day. We're being exposed to other things than COVID that we are being immunized against. And when we're younger, our immune system is much stronger and we have a better shield with regards to that immune response. And just that natural, quote unquote, aging of the immune system can lead to waning of the immune protection, which requires some booster shots and of other vaccines. So not all vaccines because of how they're made and how our body responds, but we naturally have immune aging and waning of our immune response in general, and we have waning of the immune response to vaccines in certain situations. So this is a common and often expected phenomenon, if you will. So it's nothing to point to the original vaccine that it's necessarily more dangerous or not produced correctly. And I think the other concept too, when we talk about waning of the immune response, especially to the COVID vaccine that we're hearing about that's leading to talk about booster shots, is what about in people with lupus and other autoimmune conditions or immunosuppressed conditions? And do we need, what's the importance and the response in terms of the boosters there? Well, first of all, and as many of us expected or suspected, people with lupus showed a decreased response to the COVID vaccine. In this a relatively smaller study, but still it's one of the best ones to date, Pete Ismerly and his group out of New York University showed that about almost 30, about 29% of people with SLE in their study demonstrated a low response to the COVID vaccine. And they showed that if you're on certain medications that suppress your immune system as a result of having lupus, that was also associated with decreased protection. And this was published in the journal article, Arthritis and Rheumatology. In all, this study included about 90 people, well, 90 exactly, patients with SLE, and compared it to 20 quote unquote healthy individuals or control participants. And everybody completed a COVID-19 vaccine schedule, a regimen, I think mostly 2 shots. And among those with SLE, 79% were receiving hydroxychloroquine or Plaquenil, 29% were on systemic glucocorticoids or steroids with an average dose of 7 milligrams of prednisone. Also, about 42% were using at least one other immunosuppressive drug, with mycophenolate mofetil or Cellcept being the most common at 21%, followed by Benlysta or belimumab at 11%. And about 17% of these 90 people with lupus were on more than one immunosuppressive medication. And they showed about 30% of this group had decreased response or low response to the COVID vaccine. And we'll unpack that in a minute. But one thing I want to point out also is that they checked for flares of their lupus with the vaccine, and just 11.4% of patients experienced a disease flare or lupus flare following vaccination. And among those 11.4%, only 1.3% were severe. So very severe flares, which is ultimately what we want to avoid, is extremely uncommon in this study. And flares in general, which were more moderate to mild, were just about 11% of the group. So the next question is really how much resistance to COVID-19 does someone with lupus have after getting their booster shot? We don't know. We don't know this. We know that it having a third shot, if you've gotten the 2-shot series before, or the second shot, if you got the 1-shot J&J, that additional shot will boost antibody levels, often much higher than the original 2 shots or the original 1 shot. So it's logical to assume that even people with lupus that have a lower response will have a much greater response with a booster. And so, I can see this question is important, and I know people are working on it, and it's valid to want to know, well, how much protection do I get having lupus with a booster shot? But my response for now is you're getting more protection than you were with the original series, and that is a good thing. I still like to use the car seat analogy that, seatbelt analogy that, people that wear seatbelts doesn't mean, we all do that. It doesn't mean that we're going to be absolutely protected from any harm in a car. But statistically, seatbelts help save a lot of lives. But unfortunately, there are people that continue to get hurt or pass away from very severe accidents or certain angles where they fly out of the seatbelt. It just wasn't designed to protect 100%. And so you can even look at that seatbelt and say, well, let's say that seatbelt is weaker than 100%. And I don't know what the number is. It could be anywhere from 20% to 80% weaker. That may be unsettling to not know whether is it 20% or 80% weaker, but it's giving you more protection than you would have without wearing the seatbelt. What I can tell you 100% for certain, if you don't wear that seatbelt, is you do not get any additional protection from that seatbelt. And same thing with the vaccine. If you don't get the vaccine, if you otherwise can get it, then you're absolutely 100% not getting any benefit from the vaccine. Whereas with a booster, you're getting some benefit on top of the original series. And we just don't know the extent of how much, but it is more than you got originally with the first 2 shot. So in general, we are still recommending the booster. The American College of Rheumatology has come out reviewing the data so far, and the best that we can as a specialty can recommend is with good confidence that it recommends the booster shot of the Pfizer or Moderna mRNA vaccines for people on immunosuppressive medications, which would include lupus patients. The reason they specifically stated the mRNA is that they just don't have enough data for the J&J yet, but not to say that they're doubting that J&J will be as beneficial, and most people expect that. It's just that that data is not as robust as the Pfizer and the Moderna mRNA vaccine data. And most people feel it's just a matter of time before J&J's vaccine will have similar data for similar confidence and recommendations. So I'm going to finish up with 2 more questions that came in, the last 2. How long is someone contagious after they get COVID? And my employer requires a negative COVID test. Am I still contagious after 14 days if I'm still positive? After, if you test positive and you undergo quarantine, so at least 10 days, some people, I hear jobs will say 14, but after that quarantine period, you are not contagious. It's not uncommon to continue to have a positive COVID test, especially if it's a PCR test, because of the way the test is done. The PCR test, because it's a very sensitive test, it picks up on viral particles. And so even after you get infected and all the virus dies, and that sounds gross, but little bits of the virus are going to remain in your system and in the nose until it gets cleared out. It doesn't mean you're infectious. Those are just remnants of the dead virus, and that's what the PCR is picking up. So, I don't know about the employer requiring a negative COVID test. That really, I think that's something that doesn't make sense to me. And there's a lot of scientific proof with statements from the CDC and otherwise to show that that would not be a reasonable requirement. And people even have symptoms afterwards, like coughing and this long COVID stuff that's been reported a lot. Those are symptoms as a result of that previous initial infection, but it doesn't mean that you're infectious. And the way that we know this is that there have been a lot of good studies to show that the virus isn't there to replicate. And that's what contagious means, right? You have enough live viruses that continue to live and grow. And that test is through a culture. You take that swab and you don't do a PCR test, which tests for little bits of dead particles, like I mentioned, of the virus, but instead you swab it on a medium where it allows the virus to grow, similar to like what they do for bacteria cultures. But if you see the virus on a swab from your nose growing, then that's live virus. That means you're contagious. And that's clearly been demonstrated that certainly by day 14, you're not going to be contagious anymore. What therapeutics do you recommend for people with lupus who get COVID? Is the protocol different depending on whether they're vaccinated or not? The recommendations for people who get COVID with lupus is no different from generally the recommendations for other people. We don't know enough about lupus specifically, as well as a lot of other specific conditions, to make specific recommendations. What having lupus introduces potentially are some risk factors that may raise or lower people's suspicion or risk of someone having more severe COVID down the road, and therefore being more aggressive about it. So bottom line is, the vast majority of people, with lupus or not, if they get COVID, tend to have a milder illness that doesn't require any medical intervention or hospitalization. Yes, you may not feel well, but it's not severe enough to be hospitalized or do anything differently. We don't have a cure for COVID. And most people will get over COVID after several days. And so mild COVID without any hint of breathing issues, and that's really the key here. That's what we ultimately want to try to detect, are people who will get viral pneumonia from COVID, because those are the people that, if it's severe enough, will have to be ventilated, and then those are the people that tend to die. So as long as you don't have severe viral pneumonia or low oxygen levels as a result of lung involvement, then that could be managed by being at home. If you have more severe symptoms, especially breathing issues, now just feeling short of breath may not by itself mean that you're at high risk, but that is a situation if you have more severe symptoms in general, but especially if it includes breathing types of issues, to be seen by your healthcare professional, because those are the people, especially if you can demonstrate pneumonia, especially by lung exam and by chest x-ray, and if you can demonstrate low oxygen levels by that thing that you put on your finger, that's clearly been shown as people at higher risk for having poorer outcomes with COVID. And so that's still not a time to be too concerned, but I think most healthcare providers would at that point point towards the use of monoclonal antibodies. So we want to keep people out of the hospital, and if there's any signs of lung involvement, lower oxygen levels, very severe symptoms, then talk to your doctor right away and have a discussion about the possibility of getting an infusion of monoclonal antibodies. Now, there is no strict definition or criteria along these lines, so there's a lot of other interpretation involved, and this is where having lupus and really what issues as a part of your lupus comes into play. Now, somebody just on Plaquenil that has mild joint issues from time to time has been doing generally very, very well with lupus is probably at very, very low risk of having some of these severe, especially lung involvement of COVID. But if you've had lung involvement as part of your lupus, there's already a lot of scarring in there that you've had previous chest x-rays and CT scans that show that scarring, and sometimes it would be difficult to know what is due to COVID and what isn't due to COVID, but you're feeling worse. You know, there's a lot of different combinations of things that I can bring up, but you know, that would be just one example where I would say, gosh, you know, I'd rather err on the side of giving a treatment that would make the infection less severe, especially in somebody with already known lung involvement, and it's very difficult to know what is what. So I guess the bottom line would be, God forbid, if you were to get COVID and you have lupus, I would just quarantine. Chances are much greater that it'll be a mild form and you'll get better. If you were to have more severe symptoms, especially breathing issues, talk it over with your doctor. And if there are signs that you're having more lung involvement, low oxygen levels, or you have other medical conditions that put you at very high risk for poor outcomes, then you should have a discussion on monoclonal antibodies. Okay, so again, thank you, Terry, for all that you do. Thanks for helping to organize all of this and for keeping the website updated. So a reminder to check it every now and then for updated information. This also with the national website, and continue to send your questions on the second Sundays by I think 2 o'clock, and even before then, if something comes to your mind, shoot it. If it's more urgent, we'll try to get back to you. But we'll compile all these together and we'll continue to meet every month to try to catch up with things. Thanks again, and I hope you have a great, safe week coming up, and I look forward to meeting with you again soon. Have a great day.